Okay, welcome everyone. My name is Dr. Andre Panossian, and I'm a board-certified plastic surgeon practicing in Beverly Hills, California. And I want to thank you for joining me today on this webinar on vascular anomalies, specifically about hemangiomas and other vascular birthmarks. So to get into it, I am basically I'm going to give you a quick introduction. I'm a pediatric plastic surgeon, and by that I mean that there's been additional training and specialization in pediatrics specifically. Within that realm, there's a huge wealth of patients which are born with vascular birthmarks of all types. And before we get further, I just want to remind everyone to join in with Google Plus to make sure that they are able to post Q&As on the right-hand column of your screen. And you can also follow me on Facebook at facebook.com/Dr. Panossian, DrPanossian, and post your questions. For those questions I do not get to, I will make sure to answer those by email if you go to my website at drpanossian.com. You can find my contact information and go ahead and email me. I will answer every one of those questions. So without further ado, I want to talk about why we're doing this webinar today. I think one of the most confusing parts of plastic surgery, specifically in pediatric plastic surgery, is the field of vascular anomalies. So what are these things? These are basically also known as vascular birthmarks, and they come in a variety of shapes and sizes and colors, and it's a very confusing mess. And it's such a mess that even doctors are poorly trained in this, and this is one of the sort of dissatisfactions I had about my own medical training when I was coming through medical school, is that this was not offered the way that anybody could understand, let alone try to treat some of these very complex patients. So I decided that this is one area that I would love to specialize in, and this is exactly what I ended up doing. So the problem with a webinar of this kind is that we can't cover every single topic of this. Talk alone would at least be a 2-hour talk if we were to get into the nitty-gritty on every one of these vascular birthmarks. But what I wanted to touch on the main ones that people will see with their kids having been born with them, and what makes them different from one another, and to clarify some of the diagnostic dilemmas that are present from the doctor's office. So even pediatricians can stand to benefit from a talk like this, because it does offer some real-life examples of what these birthmarks are and how to treat them. So once again, the Q&A section is on the right-hand column. Please make sure to sign into your Google Plus account to make sure to post your questions, and I will definitely answer all of those. So without further ado, we'll go ahead and get into it. Okay, so vascular birthmarks, here we go. So I have nothing to disclose financially. So jumping right into it, what are vascular birthmarks? Well, first of all, they're vascular. That means they're made up of blood vessels, and they are birthmarks. Therefore, they are present at or sometimes around the time of birth, when we, as I alluded to before, call them vascular anomalies as an all-encompassing term. Now, what are some facts about vascular birthmarks? Like I alluded to, they're very poorly understood. They're even taught very poorly in medical schools. There's bad terminology and a lot of monikers that are thrown around in their use, which even further complicates the matter. And of course, that leads to misdiagnosis. And even in our own study at Children's Hospital, we did find a 63% misdiagnosis rate, which is absolutely staggering. So again, what are vascular anomalies? To really simplify this, we break them down into tumors and malformations. So by tumors, we're not necessarily talking about cancers, but these are masses that behave like tumors. In other words, they can grow and push things aside and so forth. So the biggest one of these vascular tumors that you'll see most frequently is the hemangioma of the infantile type, which is basically kids who are noted to have them in the first few weeks of life. Within that category are some other rare tumor types. But then there's a whole other realm of vascular malformations. Now, these do not behave like tumors, and they do not appear like tumors, although they will be confused as such very frequently when they present, especially when they present in my office. They are composed of numerous types of vascular channel malformations, but most notably it's the port wine stain, for example, which is composed of capillaries. So vascular tumors, to start off at the top, is basically that it's important to note that they're benign for the most part. In the rare instance that we have a rare malignancy, that is again an uncommon occurrence. They grow usually after birth. In other words, children are not necessarily born with these tumors, but they can slowly start to develop them after birth. And again, they go away in early childhood for the most part. Versus vascular malformations, side by side, that is also benign, but they are not tumors. They don't behave like tumors. They don't grow like tumors, and they do not go away with age, contrary to the vascular tumors. So if you put them side by side, what does it look like? You have the age of occurrence is in the first month of life, typically for vascular tumors, whereas malformations are present from birth. In looking at vascular tumors, they're most prevalent in females, whereas there's no predilection in malformations. The course of these tumors and malformations is such that there's three definable phases typically: a growth phase, a plateau phase, and an involution phase with vascular tumors. And there's no specific growth pattern other than a proportionate growth over time with some sporadic expansions that can occur at various time points in development. So jumping right into the most common type of vascular birthmark that we see, it's called the infantile hemangioma. So this is again the most common tumor of all of infancy, and it occurs as frequently as 1 in 10 kids. It's usually not present at birth, and it can steadily enlarge. It usually starts off as a small rash or a blemish on the skin, and that can proliferate into the large mass, specifically the type that you see here in this picture. And they tend to disappear between 3 and 5 years of age after they have gone through the growth and plateau phases. Another set of associations, these tend to occur more frequently in females, as I mentioned. In addition, low birth weight kids, premature kids, twins will have more frequency of hemangiomas being present. And again, they mostly occur on the head and neck areas. So infantile hemangiomas can be, there's different ways to really kind of look at this, to break it down. They can be sorted out by depth. They can be superficial, deep, or a combination of both. They can include one small area, which is likely the most common type of presentation, or they can have a little bit more broad and flat surface area that they cover. And sometimes there's multiple ones, and this is sometimes referred to as hemangiomatosis. The problems of infantile hemangiomas, besides their cosmetic appearance, is that they can break down. The skin breaks down. They are typically lined with an epidermis that is very thin, and the epidermis is friable when it gets stretched by the hemangioma. It can break down and ulcerate, and which causes a painful, difficult problem. They can also bleed from these lesions, and they can bleed quite profusely. Some parents do eventually go to the emergency room, but thankfully most of this bleeding is controlled with some direct pressure, which is what I advise with all my parents. And of course, the disfigurement that can result from hemangiomas, as well as other obstructive problems. For instance, in this child, there's a visual field obstruction, which is a very important problem to relieve, and that dictates when you intervene for different types of hemangiomas. Of course, you don't intervene for all. So, as I alluded to, observation is most often recommended by pediatricians, family practitioners, and even plastic surgeons who deal with these will most often recommend observation for these, which is a good thing, and I think is appropriate in most cases. So here's an example of what these phases of the infantile hemangiomas can be. There's the growth phase, which occurs here at 3 months of age in this child. She has a growth phase that lasts almost a year, which is typical of hemangiomas, and at which point it enters the plateau phase. Over the intervening 2 to 5 years, you can see that the involution phase starts to kick in until it's all completely resolved on its own. Now, there's been a lot of talk about propranolol, and I think if you're a parent watching this, you've already Googled propranolol, which is a beta blocker. And the beta blockers typically act on a certain type of receptor on blood cell lining. And so those receptors trigger a cascade of chemical reactions which will eventually, hopefully, block the growth phase of hemangiomas. And this is what one example looks like with propranolol treatment. Here's a child who was started at 6 months of age with a very broad distribution, flat hemangioma of the entire extremity. And then she continues on the propranolol for up to 10 months of age, at which point you can see that the paleness has set into the hemangioma and it has entered a plateau type of phase. Over the intervening year and a half, you see that the hemangioma is now in the involution phase, and by 2 years, you can see that it is almost completely gone. Here's another example of a child who started at 4 months of age on propranolol, a much more severe problem in this child's case. Surgery is obviously not an option here, which can be quite disfiguring in and of itself. Therefore, and observation, of course, will leave this child with a very disfiguring condition for numerous years. So hemangioma is the best, propranolol is the best option for this particular case. And as you can see, at 4 months, we started this, and it goes from a very deep red or purple coloration to a much more pale red. And by a year and a half, this child's hemangioma has significantly begun to fade, and it is now fully in the involution phase. Now, what do we do when we offer surgery? I think surgery is reserved for very specific cases. So what type of cases might those be? I think when we're dealing with a child with a hemangioma that is obstructing some kind of function, for example, breathing or the airway, or in this case, vision, it's encroaching upon this child's visual field, you need to intervene in a little bit more urgent fashion. In this case, we excise this particular hemangioma at approximately 6 months of age, and here is the result when the child is about a year following surgery. And as you can see, it's a very flat and very well tolerated scar there. Another example of a hemangioma excision. Now, sometimes we can leave these on children's faces when they are not causing a problem. In this case, it's on the lower eyelid and upper cheek area. It is not obstructing this child's vision, and therefore you can make an argument to simply observe this particular hemangioma and let it involute on its own. However, sometimes we have to make a decision as plastic surgeons to intervene when the child is faced with a number of years ahead of her or him with this very obvious and conspicuous problem on the face. And so it becomes a source of teasing with other kids. And I think in certain cases, especially in this child's case, it was worthwhile excising this particular lesion with surgery and getting a very nice scar. Here's a look at post-op 3 weeks only, and this is just a very early scar, which continues to improve over time. Now, there are other modalities that we can use for hemangiomas, which include steroid injections and even oral steroids, which I didn't even include in this particular talk because these are slowly becoming a second and third line type of option. Not all hemangiomas can be injected with steroids, and I think the propranolol side effect profile has been very favorable thus far, and we continue to use this now as a first-line agent. Now, some people do like to recommend a timolol ointment or a cream or drops to be placed on the hemangiomas, and there have been some early studies to show that those will help as well. But I personally do prefer the propranolol due to its very regulated dosing that can be achieved in the bloodstream. So switching gears to vascular malformations. Now, this is, as we talked about, is also a benign condition, and it involves one of several vascular lines. So what do I mean by that? In this case, let's just start with an example of the typical port wine stain. This involves capillaries, and that's the type of blood vessel. And so the most famous person, I guess, is the former USSR chairman who had the very famous capillary malformation or port wine stain on his forehead and scalp, and wore it proudly. Again, these are present at birth and don't go away with time. And it's important to take 1 second to talk about another type of problem that might masquerade or get misdiagnosed as a capillary malformation, and that's the typical stork bite or cupid's kiss or salmon patch. They go by a number of different names, but basically these are much more common than capillary malformations, and they do tend to fade with time. Those that don't fade after 3 years of age can be addressed with a laser session to help lighten these lesions. Now, port wine stains are typically only involve skin. There is a certain condition that can occur where capillary malformations do go on to affect other areas, but they most often will only be present over the skin as a cosmetic problem. Sometimes, if it's over a limb, that limb can experience an overgrowth problem. And so you can see in this child with the limb length discrepancy, one leg is longer than the other and slightly wider. This sometimes can appear on kids, whether it's the arm, foot, or hand or leg. This can be a potential problem. And sometimes over time, nodules can form. As you can see on this particular capillary malformation, there's very severe nodularity happening on the scalp in one part of it. Now, as I was alluding to before, Sturge-Weber syndrome deserves a quick look. It is a capillary malformation disorder and a syndrome. In other words, there are several other aspects to this. People with Sturge-Weber syndrome can have capillary malformations in the lining of the brain. This can cause seizures and migraines to form. In addition, glaucoma is another hallmark of this particular condition. You can even see the sort of overgrowth problem happening and expanding the right side of this patient's face. Port wine stains will most often be treated with lasers. Now, the gold standard of laser treatment is the pulsed dye laser itself. It is a specific type of laser that targets the red blood cells inside of these malformations and causes them to rupture with each session. Now, they do take a number of sessions, and it's not uncommon to see patients for anywhere between 3 and 20 sessions over a lifetime to help treat areas of capillary malformations. And as I've listed here, there are other types of lasers that can be used depending on the situation. Here's an example of a laser in use. This is the pulse dye laser on a child with a facial capillary malformation. Immediately after the treatment, you can see what the laser marks can produce, and as they fade, you do get a lightening of the skin that can occur, and this will then need to be followed up with several more sessions to continue blanching out the skin and replacing the capillary malformation. Just another example over the neck. African Americans do have a slightly higher risk with laser therapy, and it requires slightly different modality to help lighten the capillary malformations. Now, switching gears to venous malformations, as the name implies, they involve veins. They're a conglomeration of these abnormal veins that can accumulate in one area or over an entire extremity, as you can see here. They're present at birth, and again, they don't go away. The venous malformations can invade bone, muscle, joints, and virtually any tissue type. And you can see here in the MRI that it really occupies in this person's forearm a whole bulk of muscle there. It does produce a challenge in terms of treatment when this occurs, in terms of avoiding any defunctionalization of an extremity or a limb while treating the problems that are associated with it, which are most often pain and swelling. The treatment options for venous malformations are typically related to conservative measures first, and we always try to employ those first before we move up the chain of therapy. So compression is very helpful from the beginning to control symptoms. Once the symptoms become aggravated in terms of pain and swelling and even cosmetic disfigurement, our biggest intervention, or the most common intervention, is sclerotherapy. Now, sclerotherapy involves injecting the pockets of abnormal veins with a specific medicine that causes scarring internally, and by doing so, causing a shrinkage to happen and destruction from within. Now, sclerotherapy sometimes requires several sessions, and again, as with lasers, this is not uncommon to have 3 or more sclerotherapy sessions to effectively treat an area sometimes over the course of a lifetime. And again, surgery can also be performed, and in this case, on this child's hand, there's a venous malformation of the palm and wrist area that were excised to help improve symptoms of swelling and pain. Uh, More often than not, sclerotherapy and surgery are used in combination with each other. So when sclerotherapy is exhausted, then we resort to surgery, and then we reevaluate, and sometimes we go back to sclerotherapy. So it's important to have a vascular anomaly specialist follow up along with his or her team to more effectively evaluate every patient. Now, lymphatic malformations I put next because they are sort of on a spectrum with venous malformations. So lymphatics drain into veins, which in turn drain into the heart and then get pumped out after they come out of the lungs as arterial blood. So lymphatic channels can also be abnormally developed, as with any other of these vascular malformations. And again, the same theme applies. They're present at birth, and they don't go away over time on their own. There's various presentations, and as you see here, there can be some blistering of the skin, which is in reality a skin involvement with the lymphatic malformation. And then what you're seeing is related to bleeding within the pockets, and they can sometimes turn black as the blood dries. And you can see in this MRI that they can be quite extensive. In this case, they insinuate into the neck structures all the way down into the outer lining of the chest and into the entire arm. So what are they more specifically? They can be cyst-like, they can cause infections. Again, pain and swelling can occur with these as well. And again, some different presentations of various types of lymphatic malformations. They all resemble each other on a microscope slide. So they are essentially the same type of problem, all benign and all do not go away. But some are more amenable to treatment than others. And I put this here just to highlight that lymphedema is a distinct entity separate from lymphatic malformations. So in this case, this gentleman has a lymphedema problem, which is related to an abnormal or an absent lymphatic channel development in the leg. And therefore, the liquid within tissues that normally gets carried away by the lymphatic channels stagnates and causes swelling in these areas. And these can be quite difficult to treat. But they are different from lymphatic malformations. As you can see, the treatment options are very similar to venous malformations. So compression, sclerotherapy, and surgery. And this is an example of what sclerotherapy can do even after one session in the right type of lymphatic malformation. And again, I say that to highlight that a vascular anomaly specialist should determine which ones will be best treated with that. Now, to complete the discussion, arteriovenous malformations need to be discussed. So what are these? These are abnormal arterial and venous channels, as the name implies. So these are much more aggressive. They are similarly present at birth and don't go away over time. And they can be quite a bit more symptomatic and debilitating. Things like simple trauma to the area or even surgery to try to remove them sometimes can cause an indirect triggering of them to expand and, in a way, grow and cause further problems. They're affected by hormones, as with any of the vascular malformations. They can be triggered by puberty and menstrual periods and childbirth. So these are very common themes among vascular malformations, but most importantly, arteriovenous malformations, or AVMs, can succumb to these problems. Now, I put here embolization. Embolization by itself has not been shown to be very effective for arteriovenous malformations. The reason for that is related to the first statement I made, in that any sort of manipulation you do to these structures, this causes a type of triggering of the problem and further expansion or growth. In this case, if you embolize or block off an arterial channel to this AVM, that causes blood to shunt away and find a different way up to the bulk of the AVM further away from where the treatment is. So these can be very challenging, and they are associated with very severe problems, including a contradictory steal phenomenon that can occur on digits or toes. And basically what that means is that despite being so much high blood flow to the area, there are shunts and mechanisms that divert the blood away from the places that they would need it most, which are the tips of the fingers and toes. And in those cases, you can get necrosis or death of the fingertips and sometimes of the entire finger. Surgery is typically quoted as being curative in medical school, but I think that, again, this has to be very judiciously used in the case of an AVM. And again, it's difficult to talk about every instance of an AVM and when to do surgery, but the vascular anomaly specialist is your guide for determining which to do. Now, I will only mention one of the combined vascular malformations, and that's Klippel-Trenaunay syndrome. And this is the reason I mentioned this particular one, is that it often gets misdiagnosed for some of the other problems, and vice versa. So what is Klippel-Trenaunay syndrome? It is by definition a vascular malformation involving all channel lines except arteries. So capillaries, lymphatics, and veins can be involved, as you can see in this hand over here, and it can be quite extensive. This is a very infiltrative one, and all the white that you see in this MRI is essentially infiltration by the veins and lymphatics within the malformation. There can be overgrowth of the limb as well as part of this syndrome. So a very enlarged extremity, hand, finger can be present. Now, treatment is again guided by symptoms, and that's a very common repetitive theme in vascular anomalies, is that we don't intervene for benign problems that can potentially cause further problems by our intervention. So as you can see here, the interventions are very similar to lymphatic and venous malformations because they are composed of lymphatic and venous malformations. Now, not all Klippel-Trenaunay syndrome individuals will be amenable to sclerotherapy, let's just say, but they may need periodic debulking surgery, and that again will be determined by a team of specialists. Now, in summary, I've gone over a very complex theme here, but I wanted to make sure that we touched on the entire scope of vascular birthmarks a little broadly, and with future webinars we'll dive into those more deeply. But to stress again, a specialist is vital for these vascular birthmarks, whether they be hemangiomas or complex Klippel-Trenaunay syndrome. They can be very complex, and there can be certain treatments that can be employed that one may not know about. Misdiagnosis is a common theme. Even to this day, it's very common to have individuals in my practice come from other practices that have misdiagnosed individuals. Treatment, as I mentioned, is based on symptoms. We typically want to treat pain, swelling, disfigurement, obstruction of vital functions, as opposed to trying to intervene based on a truly and solely cosmetic reason. Hemangiomas do go away for the most part, although there are some exceptions to that, but vascular malformations do not, and that's sort of a very important sort of a highlight to take into account. Now, for more information, please visit my website at drpanossian.com, or you can call the office at the number provided. Now, with that said, I will move over to the Q&A to see if we can answer a few questions here. So, first question. My grandchild is 1 month old and was born with a hemangioma near his eye that is very noticeable. When should he be seen by specialists such as yourself? I think that hemangiomas are a difficult problem to address without a good evaluation. So you want to make sure that hemangioma is seen by a plastic surgeon or another type of vascular anomaly specialist with surgical expertise, because sometimes those can be excised and sometimes they need to be left alone to involute on their own. And sometimes it may be indicated to use propranolol to help treat these conditions. So one of the problems that it do face is that there's a very big social concern, and a lot of parents are very anxious about their child having these types of vascular birthmarks and want some type of intervention right away, and rightfully so. I think that this needs to be really weighed out by the risks and benefits of treatment. There's nothing without risk in medicine. So whether it's a simple medication like propranolol or Tylenol even, or something as more invasive such as surgery, these interventions all have risks. And it's not the same risk for everyone. So it is not an easy answer to give in a webinar, but I will say that we do excise quite a few of these birthmarks these days, and I think that these do have an advantage to be excised early on in some cases. Another question comes in. What would you say is the most common misdiagnosis? So I think that most commonly, I think hemangioma is overused. The term hemangioma has so many different monikers that carry descriptive names such as cavernous or capillary or salmon and blue rubber bleb. I mean, there's so many monikers for it. Even port wine stain is a moniker and an eponym for vascular malformations and vascular birthmarks. It gets confusing when we use these terms, and I think that is a good question to ask, because there is a misdiagnosis rate based on how we call these things. And so if we can sort of narrow it down and call hemangioma what it is, which is a benign vascular tumor, and call vascular malformation what it is, which is a benign malformation, then I think that distinction alone will help us answer the misdiagnosis problem. So with that said, I will say the biggest misdiagnosis in my practice is hemangioma. It is frequently thrown at everything from confused with port wine stains to even Klippel-Trenaunay syndrome. That example I showed earlier gets confused with hemangiomas. And so it's a very complex discussion there with the misdiagnosis problem. But one of our goals as vascular anomaly specialists is to go out there and do these webinars and to give conferences at academic meetings across the country and across the world to discuss the problems related to misdiagnosis, which is a very big problem still. So very good question. Now it looks like we're out of time, but for those of you who have questions, please go ahead and email me at contact@drpanossian.com, and I will make sure to answer every one of those in detail. And please feel free to visit my website for some before and after gallery inspection for different types of vascular anomalies that I treat, so that you can get an idea of the services that I can provide. So with that, I thank you for joining us today, and see you soon.